Good morning to everybody. My name is Maria Diez-Campelo, and my co-chair is Dr. Guillermo Garcia-Manero. We are going to address this plenary session about the treatment on the low-risk MDS. And we start with the first presentation of Dr. Santini regarding Imetelstat treatment in this setting.
Thank you very much for this invitation. Thank you for the brave who are here at 8 on Saturday. I really appreciate it. And I will try to do my best to discuss Imetelstat. You know, it's the last approved drug for low-risk MDS. So what is the background? Now, it's not an easy background. So when I was involved in the study, in the phase 2 study, I was a little bit skeptical. So I said, why telomerase activity should be blocked in MDS? Now, the reason is, in fact, that especially in hematopoietic stem cells of MDS, you do have an activation of telomerase, especially in these cells, because they would, even if you have residual telomerase activity that is not complete, then you can maintain the dysplastic cells. And this is something very sophisticated to measure, and this is probably the background for the activity of this drug that has to be explored further. But this approach and this background hypothesis just tells you that you will have hematopoietic stem cells, so the cells maintaining MDS, hopefully, with a high telomerase activity. And if you block telomerase with imetelstat, that is a specific telomerase inhibitor, then you would induce apoptosis in the malignant cells. Now, this is simplified, of course, and there are studies going on. Simona Colla, who's an excellent scientist at MD Anderson, she's the one who can study telomerase and help us in understanding the mechanism of action. But let's talk about the clinics. So this is the study, the phase 3 part of the study, that compared imetelstat to placebo in a group of patients with low-risk MDS, unfortunately measured with the old IPSS. So the patients had to be ineligible or resistant or relapsed after treatment with ESAs. And what I put here in yellow is the most important part of this selection of patients. That is, they had to be high transfusion burden. So they had to have more than a transfusion need of more than 4 units of red blood cells in the 8 weeks. And imetelstat IV, this dose, was compared to placebo. You see that the randomization was 2-to-1. I want to stress that all subtypes of low-risk MDS were included in this study. The key point, the principal endpoint was, as usual, transfusion independence at maintained for more than 8 weeks, and then you see the other secondary endpoint. So when you see the patients where the usual age we are accustomed to in MDS, so above 70, and you see that the patients were in the majority patients who had a high transfusion need. And this is quite important. So what was the result of this treatment? I told you that the objective was to see at 6 months maintenance of more than 8 weeks of transfusion independence. And this was obtained in 40% of the cases, with 15% versus 15% of the placebo. But you also see that the median transfusion independence duration was 52 weeks for the patients who achieved more than 8-week transfusion independence. If you measure the patient who achieved 6 months of transfusion independence, you see that the TI duration was a little bit longer, and the percentage of patients, of course, a little bit lower, but you also have 18% of the total population who achieved transfusion independence continuously longer than 1 year. And who are these patients? So if you achieve 8 weeks of transfusion independence, the great majority, 2/3 of the patients, will keep it for 6 months. And if you have it for 6 months, almost 2/3 will be the ones achieving transfusion independence for 1 year. And what is quite interesting is that this transfusion independence is continuous, so there are no interruption in the transfusion independence. So what else? I think that it is quite important to see that the patients who achieved transfusion independence also had a substantial increase in hemoglobin level, more than 1.5 gram deciliter. And then that the peaks of these hemoglobin levels were increasing the longer duration of the transfusion independence. So you see here that the patient who achieved 1 year of transfusion independence continuous had a level of hemoglobin that is near normal. And I still have a patient who was included among the first ones, and he's still in response, and he has normal hemoglobin level. So he's really bothering us with a lot of requests. He's perfectly well and take care of his garden. That's why he's always cut and everything. But that's something very, very important. You see the median is 13 grams deciliter. So who are the patients who respond so well? Can we select a subgroup of patients who are responsive? Now, if we look at telomerase activity, telomere length, or hTERT, in this setting, in these translational studies, we cannot really see a kind of predictive factor. So we have to do something more sophisticated to understand whether the mechanism of action is only blocking telomerase activity or there is something else, and which are the patients who are the patients who respond better. What is sure is that when you respond and when you have a cytogenetic response, indeed, this is correlated with a long duration of transfusion independence. But what is also very interesting that has never been observed with other treatment is that if you have a mutation, and we will come a little bit more in details on that, but if you have a patient with one of the most frequent mutations, you see that upon treatment and response, the variant allele frequency of this mutation goes down, correlating with the response. And you see the placebo ones, and these are the treated patients, and the one who achieve response. So this is more or less the same. So you see that you have a decrease of more than 50% in your variant allele frequency. And this is an example with SF3B1. You see that the treated patient keeps on having lower level, low variant allele frequency. This is okay. This is also something that we can correlate with response and duration of response, as you see for SF3B1 and TET2. Now, what is very interesting and makes the observation more significant is the fact that the decrease in variant allele frequency is indeed correlated with the duration, as I mentioned, with the duration of transfusion independence. So the lower the variant allele frequency, the longer the duration of transfusion independence. Not only, but also you see the increase of hemoglobin level correlate with the decrease in the variant allele frequency of the mutation, pointing for a possible disease modification activity of Imetelstat in MDS. And now, what I actually like partially because I think that this is a measurement that has some subjectivity in it, is that not only cytogenetics, not only variant allele frequency, but also the percentage of ring sideroblasts that you see in the bone marrow is decreased more than 50% in the patients who achieve transfusion independence and respond for a long time, respect to placebo. Now, so if you put all what I told to you together, you see that clearly the patients who respond have an increase of hemoglobin, not only, but they also have a decrease in ring sideroblast. The response is associated with cytogenetic response, and you indeed have a significant decrease in variant allele frequency of the most frequent mutations. Now, we are now analyzing patients, only the 18% of the total population who achieved 1 year transfusion independence continuously. Now, these patients have, if you compare the ones who had a decrease in ring sideroblast or cytogenetic response or a significant decrease in variant allele frequency, you see that the rate of transfusion independence is really very, very high. So one comment is often that we measure the most frequently mutated genes. But you see here is a complete table with all the mutations that were detected in our patients. And you see blue means that the variant allele frequency is going down. Very few patients during the long treatment acquired new mutation that had a very low variant allele frequency. And we will see about the safety. So, okay, we have the data as second line in transfusion-dependent patients who did not respond or were not eligible to ESAs. What about using Imetelstat after other treatments? Now, in the phase 2 part of the study that was published a couple of years ago, you see the patients also could be included if they were treated before with hypomethylating agents or lenalidomide. They were less responsive, and this is why they were excluded by the phase 3, but they were again in the QTC sub-study in which more patients pre-treated were included. So these are the characteristics of patients, and we start from the easy previous treatment. Prior treatment with ESA doesn't seem to be and failure or loss of response doesn't seem to impact on response to Imetelstat compared to the patients who are not eligible to ESA. And if you see overall, these are the data of the patients who received Imetelstat after other treatments in third line or second line, and you see that the percentage of response in terms of transfusion independence, hematological improvement, even in the high transfusion burden patients was quite similar. And so I already told you that being exposed or being refractory to ESA was not so important in terms of response. But here are the data of patients who received prior Luspatercept. And you see that these patients who were treated with Luspatercept for transfusion dependence and lost response to this drug could be re-challenged with Imetelstat and obtain durable transfusion independence. The same was true in the few patients who received prior treatment with lenalidomide. You see the percentage is much lower than the one of the population after ESA, so the second line, let's say. This is third line, if you wish. And you see that the number of patients is extremely low, and one patient with del(5q) also responded. You know, and we repeated it several times during this meeting, that patients with MDS del(5q) are very, very rarely, if ever, included in clinical studies. What is not really suitable is the fact that you treat with Imetelstat or any other drug after having received hypomethylating agents. So these patients are the ones who do not respond so well. This is comprehensible because understandable by the fact that very frequently when we treat, we don't in Europe, not very often, but when you treat with hypomethylating agents, usually in second-line patients are sort of low risk, high risk, are the ones who really need to be treated more aggressively. Still, a little bit of response can be seen. So, despite the fact that some patients had 3 lines of prior therapy, you see that 1/4 could achieve 6 months of uninterrupted transfusion independence. And there were no different signals in terms of toxicity, but I will come back to these later. So there was, so these are early data, no real effect for the moment on overall survival. What about the safety? Now, when you hear talks about some other situation, low risk MDS, of course, the first worry is safety. So many years ago, I presented data on hypomethylating agents in low-risk MDS in Europe, and there was a lot of, well, noise in the room, and they said you cannot do it because they are myelotoxic. Indeed, they do work. We know that they are myelotoxic. What about Imetelstat? Because you hear a lot about the myelotoxicity of Imetelstat. So what are this safety concern? So first of all, I just want to let you know that there is not an increase of progression in the patients treated with Imetelstat. As you may see, very few patients progress to AML or to higher risk MDS. But let's talk about the myelotoxicity. Now you see that in fact, a lot of patients get thrombocytopenia or neutropenia. Well, this is true, but this is a transient effect of the drug, and you may delay the following dose of the drug, and you see that the patients are recovering. So even patients who have received Imetelstat for many years may present this thrombocytopenia or neutropenia, which is transient, not as long as the one we observe with hypomethylating agents. And for the moment, we have no real evidence that can be linked, like in lenalidomide, that is also myelotoxic in MDS del5Q, that is linked to response. But we will see, we are still working this. And then you see these are the other side effects, actually not, nothing that was really very worrisome in managing these patients. So, safety consideration. On the basis of grade 3-4 adverse event, you may delay the dose and sometimes do a second dose reduction and then a second dose reduction in case the patient does not recover the count very frequently. Oops, sorry. So these are the doses. You see, it's an IV drug and should be given with a pre-medication, although I did not see any injection reactions for the moment. So what do I want to say in the end? That we have 2 very good drugs with different mechanism of action, and I think the mechanism of action are not overlapping, so it will be very interesting to have an extra therapy for our patients. This is something that is going to be published, or it's already published in the British Journal of Hematology, and you see here for transfusion-dependent patients, this is what I think is the right treatment, especially for high transfusion burden patients. You should not treat with Luspatercept because maybe if the transfusion dependence is very, very high, you risk to fail, and you can treat here with Imetelstat. So I wish to thank all the centers and patients and family who took part of this phase 3, huge effort, but I mostly want to thank my group that is really supporting all these studies. Thank you very much.
Thank you very much. The session is open for discussion. Please go to the microphone.
Good morning, Gregor Stehle from Basel, Switzerland here. Hi, thanks for the talk. I have one of these patients too who was included in the trial at the very beginning and is still on the drug and is still not transfusion dependent, but she did not have any change of VAF. And what was a bit disappointing for me because of the disease-modifying potential, she has this MDS-associated arthritis, and there was no change in this either. So do you have any experience with this kind of symptoms, if they changed during the treatment?
Not really, not really. So the patients had the arthritis before treatment?
Yeah.
And kept it during treatment?
Yes, exactly. No change.
I have no idea. It's very, did the patient gain some other mutations, as far as you know?
Yes, she did gain one, and the others were just stable or even went up a bit. But no, I mean, they were all very high from the beginning.
Oh, I see.
And she has SF3B1, I think SRSF2, so a lot of mutations. It makes you, it can be scary, but she's perfectly fine.
Okay, so we have to study this patient. Would be very interesting.
Hi, Valeria. Hi, thank you very much. Listen, I know the focus here is on the clinical results, and there's no doubt in my mind this is an active drug. But just to return to the mechanism of action, because I think it's important for future development of targeting this pathway. To your knowledge, what evidence do we have that this drug is really engaging the target and modifying telomerase activity, telomere length, that sort of thing?
That's a very good point. Strictly speaking, we have no final evidence, and this is why we are, in this moment, busy trying to understand more deeply, selecting hematopoietic stem cells, so CD34 positive cells, trying to measure telomerase activity with and without the drug, in primary samples and in cell lines and models. Otherwise, you suspect. But we are using, apart from lenalidomide, we are using a lot of drugs, and we really, and Luspa, that we know how it works because it was built to work like that. We don't really know. So we have to understand, just also because we can select patients much more efficiently.
Thank you, Valeria, for this talk. I noticed in your safety slide that neutropenia and thrombocytopenia are common, 80% or 70% of the patient, but anemia is rare, 20%. So do you know any characteristic of those patients who experience anemia in the course of the treatment?
I think that this patient had anemia. This is happening in all the studies of low risk MDS. If you see all the drugs that were meant to treat anemia, in the beginning they have anemia as a grade 3 or 4. While you're waiting the drug to be effective and to act, you may have still anemia. I think that is not inducing anemia. This is true also for other compounds. It's just that you have to record all the grade 3 cytopenias.
Oh, it's not persistent?
No, of course not. If you respond, it's not persistent.
Thank you, Valeria.
Thank you.
So we're going to go to the next speaker, Dr. Mikkael Sekeres from the University of Miami, that is going to be talking about hypomethylating agents in lower risk MDS.
Thank you so much. I hope you all enjoyed Dr. Santini's photo of those beautiful clay roofs in Florence. We have palms in Miami, which for some reason, every time I post them around January or February on Twitter or Blue Sky, I get all sorts of hate from my northern neighbors. So this is a special message for Steve Gore, Yogan Santararajan, anyone else who cares. Yes, we should call these drugs DNA methyltransferase inhibitors, but I didn't come up with the title. So when we focus on lower risk MDS, just to kind of level the playing field, with IPSS-R, we're talking about people who have a score of 3.5 or lower. And IPSS-M, we're talking about lower risk being negative scores, higher risk being positive scores. This was an algorithm that we published in the ASH Education book about 5.5 years ago. We would ordinarily treat patients with lower risk MDS with hypomethylating agents. Certainly if they have multiple cytopenias, often we'll also use it for patients who have thrombocytopenia as a predominating cytopenia. Now, this is a slide I pulled from my slide deck from 20 years ago. Now, look at that beautiful blue background. That was all the fashion back in 2004. This is the original azacitidine study published by Lou Silverman and JCO in 2002. Shows an improvement for patients treated with azacitidine versus supportive care in event-free survival. And if you look really closely at the eligibility criteria for this study, it did allow on patients who had lower risk MDS. About 23% of patients on this study had lower risk MDS. 9% of these patients achieved a CR, 18% a PR, and 32% had quote-unquote improvement in their hematologic parameters by the definitions that were used in that study, which you may recall was actually started in 1992. Again, this is what led to the drug's approval in the United States, and a significant improvement in time to AML transformation or death. The overall response rate for all comers, including those patients with higher risk MDS, was 23%. Okay, so one question that we've asked more recently in the past few years, is it possible that less hypomethylating agents are actually more when it comes to lower risk MDS? And Dr. Santini alluded to the controversy she apparently stirred up in giving a talk on hypomethylating agents in lower risk MDS in Europe because of the potential for cytopenias. So this was a study that was led out of MD Anderson that we conducted through the MDS Clinical Research Consortium, in which we enrolled patients with lower risk MDS, with lower risk defined according to the IPSS. On this study, you can see all patients had lower intermediate 1 IPSS risk. If you then converted this to IPSS-R, probably 1/4 of patients actually did have higher risk MDS. We gave decitabine 20 mg per meter squared for 3 days, or azacitidine 75 mg per meter squared for 3 days. There was a Bayesian randomization enrollment. That's why there are more patients who received decitabine than azacitidine. On this study, the overall response rate, I'm defining overall response rate as CR or hematologic improvement, was 54%. To put that in context, historically, a lot of single center studies have reported an overall response rate of about 35%. So this bettered that by 20%. And that 35% overall response rate was kind of repeated over and over and over again in single institution studies. The transfusion independence response rate for those patients who were transfusion dependent was 32%, and that lasted for 22 months. The median overall survival, remember, in this patient population that was mostly lower risk, was 33 months. So based on this, I personally started to treat my patients with lower risk MDS with either 3 days of decitabine or azacitidine, or occasionally 5 days of azacitidine. Based on these results, which I really believe, I don't think that 7 days of azacitidine or 7 days or 5 days of decitabine in patients with lower risk MDS is standard. I do think that that is too toxic. I'm going to show you some preliminary data that we've submitted to EHA, another trial that we conducted led by MD Anderson, in which patients were randomized to getting 3 days of azacitidine, 3 days of decitabine, or 5 days of azacitidine. Those who got 3 days of azacitidine received it for a median of 7 cycles, 3 days of decitabine, 9 cycles, and 5 days of azacitidine for 10 cycles. Almost 250 patients were enrolled. You can see the median overall response rate in those patients who were transfusion dependent was pretty similar across those arms, slightly higher for those patients who got 3 days of azacitidine or decitabine. The median overall response rate in those patients who were transfusion independent looked to be slightly higher in those patients who got 5 days of azacitidine, but that wasn't a significant difference. When we looked at event-free survival, again, it was pretty similar across arms. There was a significant difference in the overall survival, though, for those patients who got 5 days of azacitidine versus 3 days of decitabine. Among transfusion-dependent patients, among transfusion-independent patients, similarly, the overall survival appeared to be a little bit better for azacitidine 5 days versus decitabine 3 days. We are still sussing through these data, so right now I'm hedging a little bit about whether I think 3 days of decitabine, 3 days of azacitidine, or 5 days of azacitidine should be the standard for patients who have lower risk MDS. Now, this study was led by Dr. Garcia-Manero, of course, was the oral decitabine cedazuridine combination in patients who had intermediate 1, intermediate 2, or high-risk MDS along with CMML. This is a mixed population, therefore you're going to see a median overall survival. That's going to be a little bit mixed as well. When you look at the overall response rate, I focus again on CR, PR, and hematologic improvement. It comes in right around that kind of 35 to 40% range. That's about what we would see with IV decitabine. That's about what we would see with azacitidine over now a couple of decades of studies. The median overall survival duration was 18 months, and again, that's about what you would predict from a mixed population of patients who had lower risk MDS and higher risk MDS. Now, Guillermo also presented data at ASH this year looking at oral azacitidine in this study, kind of similar to what we saw with the oral decitabine results as well. Median age was 72 years. Patients had a mix of MDS, CMML, a little bit of MDS, MPN overlap. Prior therapy included ESAs, hypomethylating agents in a small percentage of patients. But most patients, I think, were untreated coming on to this study. Again, the IPSS-R risk group showed that about 33%, one-third of patients had higher risk disease. The remaining 67% had lower risk or a little bit of overlap with the intermediate risk. So again, a mixed population. And in this study, of patients who were transfusion dependent at baseline, 38% and became transfusion independent for 8 weeks or longer. Of the 20 patients who proceeded to transplant as an alternative therapy, 19 proceeded to transplant before achieving a best response of CR. When you look at the overall response rate for this, again, it seems to be falling out to that kind of 35 to 40% range. When you look at the median overall survival, it reaches a little over 2 years, which again is what you would expect from kind of a preliminary look of patients who have lower risk MDS and higher risk MDS. Now, we've heard a lot of presentations in this conference on artificial intelligence and machine learning algorithms. This was a study that we published a couple years ago looking at a model to predict HMA response in MDS. I think one of the reasons this is important is that we know there are some patients who will be treated with hypomethylating agents, lower risk MDS or higher risk MDS, where they're not going to respond. And it's great if we can get a glimpse of that early on so you don't expose patients to 4, 6, 8 cycles of therapy before you declare victory or defeat and then have to move on to another agent. It would be great if we can figure that out within the first couple of cycles of therapy and move patients on to another therapy when it's unlikely they're going to respond. So this was a study that included over 500 patients from 3 institutions, all of whom received 4 or more cycles of hypomethylating agents. They had serial CBCs available for the first 90 days of treatment. They had more than 6 months of follow-up. And again, we looked at machine learning or artificial intelligence programming to determine likelihood of response. Patients derived from Cleveland Clinic, Moffitt, and Stony Brook in Toronto. These patients tended to have lower risk MDS with a low mean blast percentage. And when you look at important variables that predicted whether or not patients would respond to hypomethylating agents, most of these were all clinical parameters. These are things that you could, for the most part, get out of a CBC. Hemoglobin, platelets, and RDW came out. It's so fascinating to me how RDW falls out with patients with lower risk MDS and CCUS, right? It keeps on being recapitulated. I'm still not sure I understand why that is when RDW is kind of like a confidence interval instead of a discrete number, but there you have it once again. And these, the predictive algorithms could effectively stratify patients who had a very low likelihood of responding all the way to high and very high likelihood of responding. Obviously, those patients falling into the high and very high likelihood of response would remain on hypomethylating agents. But you can see here where patients falling into the very low or low categories should be pulled off of hypomethylating agents after being on those drugs for 3 months and move on to a different agent early on. So I want to thank all of you for listening, and I'm happy to take any questions.
Mikkael, whenever I listen to you, you are raising some thoughts. And I would like to take advantage of you are thinking out of the box. I have always a problem. Why are we seeing response rates in most patients with low-risk MDS? Something like 50%, okay? If you go back, ESA, 50%. Luspatercept, about 40-50%. Imetelstat, 50%. Low-risk MDS with hypomethylating, you show also. Why are we stuck with the maximum 50%? Why can't we raise? Should we do more combinations? What do you think? What should be the next step? Because we are stuck for 2 decades with this 50%.
And as usual, Moshe, you ask incredibly insightful questions that are difficult to answer. So I think there are a couple
You're the one to answer these questions.
I think there are a couple of things going on. So first of all, I don't think our response criteria for lower risk MDS are used consistently. And I think an example of that is how we define CR, right? So sometimes we define CR in lower risk MDS as somebody who has lower risk MDS but has excess blasts. So they go from 6% blasts to 3% blasts, and we say that's a CR. Other times, and FDA is actually moving in this direction, it's a patient who has relatively normalized blood counts irrespective of baseline blast percentage. I'm actually surprised FDA is buying into this, but we've had a couple of collaborations with FDA where they've said, yep, we're good with that. So you have a patient who starts out with 3% blasts, for example, and let's say they have some anemia and thrombocytopenia, the hemoglobin rises to over 10, the platelets to over 100,000, FDA is okay calling that a CR. So I think we, first of all, have variably been applying these definitions in some of these trials. And as you saw in Dr. Santini's presentation, whenever you have a response rate to placebo of 15%, my God, I'd love to get that placebo, right? So it means our response definitions are too puny, right? And that's why we need to expand transfusion independence response duration to at least 16 weeks. And there's some face validity to that also. If you said to a patient, I'm going to put you on a drug and you know what, it's going to get you 8 weeks without a transfusion, but you have to come in here every 3 weeks to get that drug, that doesn't make any sense. But if you say to a patient, we can get you 4 months, 6 months, 8 months without a transfusion, then it seems like it's a little bit more worth it. Why can't we go above that 50%? I think it's the heterogeneity of the disease, right? We design clinical trials where patients have to have good platelet counts, good neutrophil counts, but they have to be anemic. We're self-selecting for specific subtypes of MDS, such as patients who have ring sideroblasts or SF3B1 mutations. So then we try to use it in other patients, and it doesn't work so good. So there's something to the biology and the difference within lower risk MDS that we're, there's a phrase in the US called juking the stats, right? You're doing things deliberately that are going to force the results of a study to be better than they should be in a general population, and we're actually responsible for that.
Thank you.
Thank you.
Right?
Next presentation by Nicolaus Kroeger from Germany, Upfront Allogeneic Transplantation in Low Risk MDS. Thank you.
Thank you very much, and thanks the organizer for inviting me. Thanks everybody to be here on Saturday morning. So I have the, let's say, difficult task to give you an overview about upfront stem cell transplantation in low-risk MDS. I have no picture from my university, so I apologize, but I have the blue background, which is very optimistic, so let's see. So when we talk about allogeneic stem cell transplantation in general, what we can see is that due to the development in lymphoid malignancies, especially immunotherapy, the numbers of allogeneic stem cell transplantation in lymphoid malignancy has reached a plateau. But if you look to myeloid malignancies, especially AML, but also MDS and MPN, the numbers are steadily increasing. And this is because there are a substantial lack of effective drugs which can replace allogeneic stem cell transplantation. And more importantly, especially for MDS, is it's now becoming the second most frequent indication for allogeneic stem cell transplantation. These are data from the EBMT. This is a European registry. but this holds true as well for the American Society of Hematology and Stem Cell Transplantation. So regarding allogeneic stem cell transplantation in MDS, we have now some, let's say, evidence that allogeneic stem cell transplantation can be done in patients with MDS. These are not randomized studies. These are studies based on donor availability. And one of these is the BTM study, which was published recently, clearly show for patients 50 to 70 years of age with high-risk MDS, there's a benefit for overall survival. Similar results have been presented for Europe. This is a German trial using 5-ASA as induction, then followed by allogeneic stem cell transplantation or maintenance with 5-ASA. You can see also a benefit, at least at the short follow-up for the event-free survival, but also a trend for overall survival. And there's also a French study which has published by Marie Robin through 2015. And what you can see in all these studies is there was a benefit in survival, except for the German trial was only for event-free survival. But if you look to the inclusion criteria, even if patients were included more than age of 60 years of age, which represent the current age of MDS patients, all patients are treated also for high risk or intermediate 2 according IPSS or IPSS-R. So only very few patients with intermediate 1 with poor cytogenetic were included, but this has been held only for higher risk MDS. So when we talk about low risk MDS and when we look to the different scores which are available, so we talk about the evidence is only based on intermediate, moderate, high, or very high, but these are patients who have a median survival of only 3 years. So the low-risk MDS, so if you look, and we have to consider low-risk MDS means that the majority of these patients has a median survival of only 5 years. And usually in other hematological disease, if you have a median survival of only 5 years, we don't call it low risk, yeah? It's still a higher risk. And this has to be taken into consideration when we talk about strategies, how we can improve really also in low-risk MDS patients. We have also to consider what is the median survival of patients nowadays who are not sick. And this is from the German registry, but it's the same in other European countries and the US. This is the median survival nowadays in the general population. And if you look to, let's say, a patient with 60 years of age, the female has a median survival of 25 years still, the male 25 years. And even if you are 70 years of old age, the median survival still is 16 years for female and about 14 years for male. And even the 80 years had still a survival of more than 10 years. So that means there are still patients with low-risk MDS, whatever you treat them, they will lose some life expectancy in comparison to the general population. And I think this is something which we as a community should really always consider, that we need to, this is a clear unmet clinical need for these patients. So coming to low-risk MDS, so when you look to the literature, there is actually only one study which is published now a couple of years ago, 2017, by a Chinese group, and they randomized patients with MDS, and they call it low risk. And if you look very carefully, so they were randomized to best available therapies. Or at this time point in China, it was not 5-ASA, it was different other agents for 90 patients in the non-HST group, 90 patients in the stem cell group. So you can see 1/3 of the patients were classified according IPSS as low risk, but also intermediate 1 risk. But they included also 1/3 of patients with intermediate 2 risk. And if you see this publication, there was a clear benefit in disease and overall survival for hematopoietic stem cell transplantation. But they included also some high-risk patients, and unfortunately in this study it was not distinguished between the lower risk and the higher risk MDS patients. So we don't have any prospective randomized studies which are more evidence-based. So when we look to registry studies, and this is one of the very few studies which has been published for low-risk MDS in transplantation, and this was from the EBMT, from our group. So you can see in this retrospective study, so at least in the registry, there were 246 patients with low-risk MDS included. You can see here the IPSS. IPSS, it was low or intermediate. However, this was the old IPSS. If you reclassified this patient according IPSS-R, you can see there were also a substantial number of patients with high-risk patient included. So nevertheless, also survival was acceptable, was about 60% in those patients, and patients with non-T cell depleted and having sibling transplantation have actually the best results. So I think you need a more stratified. So if you look to a larger center who select patient more carefully, this is from our institution. So what we did in the last 20 years about, so at least we transplanted 60 patients with low risk MDS. You can see the median age was a bit younger than we see for the higher risk MDS, but you can see also patients up to the age of 75 were included. According IPSS-R, so there were even 2 patients, very low risk, but the majority was low or intermediate according IPSS-R. Here you can see the reason why these patients received allogeneic stem cell transplantation, mainly because they failed to EPO, or they have a high transfusion frequencies, or severe neutropenia, or even were refractory to 5-ASA or lenalidomide, or had poor cytogenetic. So when you look to the data, it's quite good. So the relapse was actually less than 10% here in the follow-up, and also the non-relapse mortality, which usually is a high barrier to recommend patient allogeneic stem cell transplantation, was for those who has an identical sibling or identical match unrelated donor, it was less than 10%. Only those who has mismatch donor has a higher non-relapse mortality. So even those patients, so the overall survival is nearly 80% in this patient, so quite impressive. And even if you look to patient-specific risk factors like Karnofsky index, a good Karnofsky was even 90%. And if the patient has HLA matched, as mentioned before, survival was very good with 90%. So there might be some room for some patients with low-risk MDS. And the other concern, at least from my point, is the clonal evolution in low-risk patients with poor cytogenetics. So there are data from 5-ASA, but also from others. And this is a study from the Japanese, which was published already nearly 10 years ago. And at this time, when I looked for genetic risk, P53, and RAS-CBL and complex karyotype, especially for the P53 mutated patients. And you could nicely see if those patients were transplanted in a later stage of the disease, outcome becomes much worse than those who were transplanted in lower risk MDS. So since we don't have really clear evidence for transplant lower risk patients, what we can do is to do so-called decision models. And this has been investigated already a couple of years ago, starting by the Markov model, by Cutler, but then other multi-state models, and more recently also the IPSM with a more sophisticated model. But if you look very carefully to all this according IPS, IPSS-R, or WPSS, and more recently IPSSM, you can see at the end, actually in all these models, there was a clear recommendation for immediate transplantation in higher risk MDS, while in most lower risk MDS, the recommendation was to delay the allogeneic stem cell transplantation. Just briefly to the more recent decision model, because IPSSM is becoming now the standard of classification and treatment selection. Though this is a micro-simulation of randomization, and just briefly, here you can see the loss of years. If you go for transplant later, you can see the different age categories, but clearly for the higher risk MDS, it's clear, but we talk about low risk and moderate low. You can see as younger, you should delay the transplantation clearly, but once you become older, you still have to delay transplantation according to this model, but you can see the curves are not as high as they are here. So the only benefit from the IPSSM regarding indication for transplantation is the movement from the IPSS-R, so going for a low-risk patient, so at least 19% of the low-risk patients according IPSS are now classified as high risk, which need immediate transplantation according IPSM, while they are the other way around, they are also intermediate risk patient, which become in 15% now a low-risk patient, which should recommend the delay of stem cell transplantation. So currently the state of the art still is, according the consensus conference, this is a consensus from the US, together with some international partners. So the question was, should allogeneic stem cell transplantation be performed routinely early for low-risk MDS? It was a clear no. And if you look to the European, which was recently updated in blood, is also patient with very low IPSM risk are not routinely approaches for stem cell transplantation. So how should we really confirm this is the standard? But I think there's still room, and I think still we need more data, and we need to investigate this curative treatment approach. So what has not been included in all these models is, and what we heard from disease-specific treatments, is predictive models. So all the models are prognostic models, but we need predictive models. And if you look for stem cell transplantation, the risk factors for stem cell transplantation are different from disease-specific factors. There is some overlap, but they are different. So what the community did in the last year in stem cell transplantation is to develop predictive model for the outcome after stem cell transplantation. Although that means even if you have low-risk patient, they can benefit more from transplantation, and high-risk patient, they don't benefit from allogeneic stem cell transplantation. So this is, for instance, a European from the EBMT. You see, you have other factors in the transplant-specific risk factors. There are also disease-specific factors, cytogenetic and blast. But here you have age and performance status, which is more patient-specific. And in others, you have also the donor availability. But you can see with this transplant-specific risk factor, you can also classify patients in high and low risk, resulting from survival more than 80% or survival less than 30%. Another was recently published, or just published a couple of years ago by the Italians using this score, which include also age, which include also age, but monosomal karyotype, refractory to chemo, but also the comorbidities index, which is very important. Here can also distinguish patients regarding outcome with low risk, more than 80%, and higher risk with very low outcome. Also, the validation was done according to the IPSSM more recently, and here you can see ages, performance status, monosomal karyotype, P53 absent, and you can have also nicely distinguished outcome after stem cell transplantation. So it might be useful if you have patients which are potential candidates for transplantation. So in all these risk factors, if you have, for instance, a low transplant-specific risk factors, then you have a survival of about between 70 and 80%, which is quite useful. And I think this needs to be in this sharing process, participation process, explained to the patient very carefully, and then they will select for the indication. So therefore, the clear indication was a bit relative. So in the EBMT, the European, it was a bit modified. So in those patients with low or moderate IPSM, the possibility of transplantation should be considered if there's a germline predisposition, for instance, or those who are transfusion dependent, severe cytopenia who did not respond to treatment, but also patients with therapy-related MDS, which are not, or hyperplastic MDS, which are currently not clear in the current risk prognostic scoring established. Also severe cytopenia, transfusion burden, or failure to immunosuppressive therapy. And similar has been done by the US colleagues. So, however, there might be scenarios in which patients should be considered allogeneic stem cell transplantation, younger age, transfusion dependency despite best supportive cares, or multiple or adverse somatic mutations. So our current approach is here. So we classify all IPSSM. So there is, in our opinion, indication for those patients lower risk who failed the therapy which are approved, which is listed here. But there are also some where you consider upfront transplantation, which is the topic of my talk. And this is mainly based if germline mutations, bone marrow fibrosis, abnormal cytogenetic or progressive cytopenia, especially where we recommend we'll go like we do in high-risk MDS for selection the patient for allogeneic stem cell transplantation. And with this, I want to end and thank you for your attention. These are all the people who worked on this field to improve outcome in MDS patients by allogeneic stem cell transplantation. Thank you very much.
Thank you. I'm David Valcárcel from Barcelona. Very nice talk. So from the results you showed, the main problem is not relapse as in the higher risk. So which is your recommendation regarding treatment before transplant and the transplant platform, conditioning, T-cell depletion or not, in this specific population where we do patients to be lived without GVH?
When we talk about lower risk MDS,
yes.
So a lower MDS, usually if we go for stem cell transplantation, they don't need any blast reduction therapy because usually they don't have a higher number of blast. Usually we go there for reduced intensity conditioning only without any pretreatment. If they have received a lot of transfusion and if they have a high iron overload, we include, for instance, the exjade within the conditioning regimen to lower the LPI, to lower the toxicity, but then you have to monitor closely busulfan level if you go with busulfan because there's some interaction. And so reduced intensity without any pretreatment for low-risk MDS patients.
And would you suggest any particular GVHD prophylaxis for this kind of patients?
Yeah, so we would recommend to go with cyclosporine and MMF or MTX, but we would recommend in all patients, in MDS patients, go with ATG or PTCy as additional GVHD prophylaxis.
I think actually we are under transplanting in low-risk MDS. And I think something that it doesn't come in some of these models is the sequence of therapy. So for instance, Dr. Sekeres just presented the data with hypomethylating agents in low-risk MDS. For us, a low-risk HMA failure is a clear indication for transplantation, and the results actually are exceptional. So I think in this analysis, we need to start thinking about what do you do, even if you have low-risk disease, but now you fail Luspatercept, Imetelstat, HMA, those patients are still there. There should be some way that we figure out what the role of the transplant is. So I don't know if you have a comment about this. And the second, very quickly, is this phenomenon that now we call upstaging of the disease, because a lot of the data that we're talking about is based on IPSSR, even sometimes actually IPSS. But you have this phenomenon of patients that have quote-unquote lower risk characteristics, low blast, maybe the cytogenetics are not that bad, but with a significant molecular burden, so higher risk by IPSSM. And I think that may be potentially another group of patients that we could think about more aggressively pursuing transplant. I don't know what you think about this.
No, I agree completely. We need to transplant more patients with low-risk MDS, definitely, yeah. But we should have a more, let's say, communication between the classical hematologist and the transplanter. Usually the transplanters, they have their own bubble, yeah. They use the transplantation only, but also the hematologist or MDS community is also in a bubble, yeah. Therefore, I think for me, as let's say general hematologist, we go more far rather than together currently, yeah? We go out, yeah? And we have to include also patients to have also patient-specific decision finding, yeah? And if we explain everything clear regarding survival, non-relapse mortality, risk of relapse, and so on, and then you can see the patient decision is sometimes different from that what we decided, yeah? And we are currently in the process to accept this, yeah? So, and the problem I see with low-risk MDS is because we are more or less referral center for transplantation, we see patients too late. They are low risk and they got all the drugs, yeah, but they were sent when they come to secondary leukemia, yeah? It's too late, actually. And what has to be done, actually, is because we have these models, delay transplant, but delay means what, yeah? When is the time point, yeah? Should we transplant low-risk patients when they become high-risk or intermediate 2? Or should we monitor them closely? Because all with the new drugs you will have the clonal evolution in behind, yeah? Even if you have a good hemoglobin, and if you check very carefully, regularly, NGS, you will see you have additional mutations. And we should find ways, when is the right time point, and how should we monitor this patient, low-risk patient, according NGS, for instance, yeah? And because we can clearly see the lower the risk of the patient from the disease, also the outcome is better. Of course, we have non-relapse mortality, but as you can see, if the center is experienced and can select patient, it's 10% or less. But you have also morbidity with 5-ASA, yeah? This is also underestimated. We lost a lot of patients by 5-ASA before we go to transplant, just from infection complication.
There's a question?
Yes, hello. Lena van Baar from Sweden. Thank you very much for an interesting talk. I was wondering, you mentioned germline predisposition as a reason to move directly to transplant, but the most common germline predisposition is DDX41, where we usually have a bit better prognosis. Could you comment on the indication for allo in DDX41?
No, actually, this is the guidelines from the European, yeah. I don't think the experience is quite limited currently going for transplantation. But usually, if you go for DDX1, especially in leukemia, for instance, the outcome is pretty good in these patients. So this is a recommendation. I personally have no experience going with germline mutation and allogeneic stem cell transplantation in MDS.
One more quickly.
In high-risk setting, we have sometimes concern that we do select clones pre-transplant by HMA. I think there's no data about this in the low-risk setting, but have you any clue in your data that people that are pre-transplant treated with HMA are doing worse after transplant than the rest?
So data are not available so far. I mean, the major thing is regarding clonal evolution, because it was not tested in this patient. So usually if you treat with hypermethylation, you don't look for NGS every year or so. I mean, what really the problem is, because if they become cytopenic and if they become then infectious complication, so they have, most of these patients then have some infectious still, they have fungal infection and all these things, which actually worse the outcome after transplant because you have a higher risk of non-relapse mortality.
Thank you very much. So our next speaker is Manja Wobus from Germany.
Good morning. First of all, I would like to thank for selecting our abstract as an oral presentation at that meeting. So even though that I'm somewhat of misplaced in that treatment session, I hope that I can meet your expectations and convince you about the potency of targeting the immunosuppressive microenvironment in low-risk MDS. So this is a preclinical study, it's an ongoing study. These are my disclosures. So we have already heard a lot about the important role of the inflammation and immune dysregulation in driving MDS pathogenesis. The alarmines S100A8 and A9 play an important role in setting up and driving inflammation in the bone marrow. They increase the expression of pro-inflammatory cytokines such as IL-1, IL-6, and TNF-alpha, which then leads to clonal hematopoiesis, dysplasia, and myeloid squeezing. High levels in the bone marrow of S100, A8, and A9 have been associated with poor prognosis for the patients. And this has been shown both for the leukemia-free survival, but also for the overall survival of the patients. So S100A9 binds to TLR4 receptors, besides also to CD33 and RAGE. the binding to the receptor activates an intracellular signaling cascade via TRAF6, IRAK1, IRAK4, leading to activation of NF-kappa B transcription factors, which then activate the transcription of the pro-inflammatory cytokines, which then lead to driving of the inflammation, increasing the NLRP3 inflammasome in the cell. So we are thinking about targeting that pathway at the very top, at the binding site of S100A9 to the TLR4 receptor. And we have heard in the talk of Amit Verma on Thursday that they introduced or they developed a neutralizing antibody against this. We came across about a small molecular drug called Tasquinimod, which was developed by a Swedish company, Active Biotech, as an S100A9 inhibitor, and it was initially proved in solid cancer models and clinical studies, but it is currently also in clinical investigations for multiple myeloma and myelofibrosis. We could show that Tasquinimod inhibits the S100A9-mediated TLR4 downstream signaling in mesenchymal stromal cells, which restored their hematopoietic support capacity. And translating these findings into an in vivo model of an MDS mouse model, these were the NHD13 mice, which have been treated with Tasquinimod for 12 weeks. We could demonstrate that the treatment resulted in significantly higher red blood cell counts as well as higher hemoglobin levels in these mice. Mesenchymal stromal cells play an important role, or have a central role in the bone marrow microenvironment, not only for the support of hematopoiesis, but also for the immunomodulation. And as you can see on this figure, they are in interaction with almost all immune cells, and this is facilitated by a number of cytokines and growth factors, and a very prominent one is PGE2 in that context. So in that study, we aim to evaluate the effects of S100A9 and inhibiting by Tasquinimod on the MSC immune cell crosstalk, especially on monocytes and macrophages and T cells. To conduct this study, we established different co-culture models in which we cultured mesenchymal stromal cells from low-risk MDS patients and from healthy donors, which were co-cultured with monocytes and T cells from healthy donor PBMZs in the presence or absence of Tasquinimod. And for the co-culture settings, we have 3 different conditions. The first one is the direct co-culture, and then we have 2 different conditions for the transwell setting. Transwell 1 is, in the transwell 1, the MSCs are in contact with monocytes and the T cells are separated in the upper compartment. And in transwell 2, the MSCs are separated in the lower compartment from the 2 other cell types in the upper one. The downstream assays were flow cytometry analysis for phenotyping of monocytes and macrophages. We assessed the PGE2 secretion by ELISA and analyzed the T cell proliferation. So as a start, we showed that myeloid cells are the major source of S100A9 in the bone marrow by performing immune fluorescence staining. And we've detected co-localization of CD60B and CD68 with S100A9. After having confirmed that monocytes express high levels of S100A9, which could be decreased by the addition of Tasquinimod, we co-cultured these monocytes with MSCs and found an activation of inflammatory molecules in the MSCs, which could be clearly decreased by the addition of Tasquinimod to these co-cultures. Before I would like to show you the data about the monocyte phenotyping, I would like to remind you about the different monocyte populations due to maturation and differentiation. So the classical monocytes express CD14 and have no expression of CD16. Then there is an intermediate population expressing both molecules, and the non-classical monocyte population lose CD14 expression but have high expression of CD16. When we co-cultured monocytes with MSCs, we detected a shift to the intermediate population of CD14 positive, CD16 positive monocytes, and the addition of Tasquinimod clearly decreased the intermediate population and increased the non-classical monocytes, which have been suggested to be less inflammatory. Sorry. Next, we wanted to analyze the macrophages and the subtypes of macrophages, and we used CD86 expression as a marker for the M1 population of our macrophages, and we could detect an increased expression of CD86 after Tasquinimod treatment, so that suggests that Tasquinimod increases co-stimulatory signals which are necessary for the activation and survival of T cells in co- and triple cultures. On the other hand, the expression of CD206 were decreased by the addition of Tasquinimod, which is a marker for M2 macrophages, and this could be suggested that Tasquinimod elevates the immunosuppressive state of M2 macrophages in the co- and triple culture settings. As already mentioned, prostaglandin E2 is an important mediator of immune cell regulation, and interestingly, we detected a significant increase in PGE2 secretion levels after the treatment of co-cultures with Tasquinimod. However, this is only happen when MSCs are in contact with monocytes. Finally, we analyzed the T cell proliferation, and whereas the treatment of T cells with Tasquinimod had no effect on their proliferation, the addition of monocytes and Tasquinimod could clearly increase their proliferation, and this setting was then used as a control for the further experiments. So whereas addition of monocytes increased or induced T cell proliferation, the addition of MSCs suppressed this T cell proliferation, and Tasquinimod could partly counteract these effects. However, MDS MSCs in direct co-culture with a contact to each other impede this effect. So to sum up, we proposed that Tasquinimod may act as a selective modulator of MSC monocyte interaction, which leads to an limited inflammatory cytokine release. It leads to decreased inflammatory monocyte and macrophage populations. It results in an increased PGE2 level and its anti-inflammatory effects, which might promote anti-tumor cell anti-tumor T cells while reducing Tregs or their suppressive activity. Overall, it reprograms the microenvironment for balancing the T cell responses. So that's why we think low-risk MDS patients with cytopenia might have a potential benefit from treatment with Tasquinimod by preventing the disease progression. And we hope that we can start a clinical phase 1 trial very soon. At the end, I would like to thank all the people who have contributed to the work. It was mainly performed by Tom, a very talented bachelor student, and Annalena in my group. I would like to thank all the collaborators, funding sources, and you for your attention, and I'm happy to take questions.
Thank you very much. Very nice. My question is, as you know, the shorter effect of S100 and longer term effect is different, and when longer term effect is remodeling of MSCs and basically then perhaps blocking it doesn't work much. I'm just wondering whether you try to test and confirm this by culturing a longer term and then block and see whether it makes a difference, or get patients higher risk or AML MSCs to see whether it makes any difference.
So we haven't, for our in vitro models, of course, we tested different time points, and starting from 3 days to 7 days until 14 days of culturing with the treatment. But we do not have tested it for a longer time in these 2D in vitro models. I think this would be worthwhile to try to set up in a 3D model of all the co-culture or triple cultures, and then also longer culturing periods should be possible. The mice were also treated for longer periods. It keeps the effect, but it doesn't improve it.
Yeah.
So, still,
that's what you expect, basically.
Yeah.
Yeah. Okay. Thank you.
One question is regarding your effect on hematopoiesis. Do you think that this, when you modulate the immune system, you can have a positive effect on erythropoiesis or hematopoiesis? Because in the lower risk, we need to improve. So if your drug has not this effect, you should combine with another improving erythroid.
Yeah, we have this investigated, and this was actually done in the very first experiments when we co-cultured the stromal cells with hematopoietic cells and differentiated these also under the influence of GM-CSF, and we could clearly see an improvement of the erythroid colonies and a decrease of the myeloid ones, which is perfectly what we expected and would like to see. That fits very well.
Thank you.
Hi, can I have another question?
Yes.
There are some data, not that clinically much expressed, but Tasquinimod has been analyzed in multiple myeloma patients, especially in relapsed refractory setting, and they have shown that in combination with some immunomodulatory drugs like lenalidomide or bortezomib, which is proteasome inhibitor, there can be some response. Do you think that Tasquinimod in the future, maybe in MDS patients low risk, can be combined with some kind of immunomodulatory drugs to increase the efficacy?
Yes, very good point, and of course I would say that this is really worthwhile to prove, and we had, especially for lenalidomide, although it might be effective only for a smaller proportion of patients with a del(5q) mutation, but yeah, this I think Tasquinimod might be even better in combination therapies in the future.
Our last presentation is entitled ESA plus Luspatercept after Luspa failure in patients with MDS or MDS-MPN with ring sideroblasts, a retrospective real-life study by the GFM, and is presented by Thibault Comont.
Well, good morning, everyone. I want to thank the scientific committee to select this study conducted on behalf of the group francophone of Myelodysplastic. Well, as you know, low risk MDS with ring sideroblasts are characterized by chronic anemia and transfusion dependency. Until recent years, the only available treatment was ESA. Then Luspatercept was approved based on the Medalist trial in MDS or MDS-MPN with ring sideroblasts with transfusion dependency and ESA failure. Pierre Fenot resumed all the results yesterday, so we can move forward. As you know, biologically, EPO stimulate early erythropoiesis stages, while Luspatercept promote terminal erythroid maturation by inhibiting TGF-beta superfamily signaling. So, considering the complementary mechanism, provide a rationale to combine these agents in a subset of patients. Moreover, combine two agents with a limited efficacy as single agent may provide a synergistic benefit, as previously reported in this study conducted by the GFM, combining lenalidomide to EPO in low risk MDS after EPO failure. Recent studies confirm the potential interest of combining Luspatercept and ESA in this setting. The first one was conducted in US on 28 patients, mostly after ESA failure, and the author observed a transfusion independency in 32% of patients with an overall erythroid response of 36%. The second study was conducted in the Czech Republic, and in a subset of 31 patients who were refractory to ESA then Luspatercept, they observed a transfusion independency in 51% of them. However, real-life data study are still limited in this setting, so we need more data. So the objective of this study was to evaluate the efficacy of the combination of Luspatercept and ESA in a population of patients with MDS or MDS-MPN with ring sideroblasts who were refractory to both ESA and Luspatercept as monotherapy. We conducted a retrospective study in a real-life manner across the GFM centers, and we first included patients with low-risk MDS or MDS-MPN ARES according to WHO 2016 who failed ESA in the Luspatercept registry. Then some of them received the combination after Luspatercept failure of ESA and Luspatercept were included in the study. We retrospectively analyzed the response at week 24 for Luspatercept monotherapy and at week 16 for the combination. The primary endpoint was 8 weeks transfusion independency according to IWG 2018. But we also evaluated the overall erythroid response and also the safety and treat to identify a prognostic factor of response. Well, 187 patients received Luspatercept as monotherapy, and to note, at week 24, we observed an erythroid response rate at 50% approximately, and 30% of transfusion independency, which is closely similar to previous reports. But I will not go into further detail to the monotherapy result, to focus to the subset of 54 patients who received the combination. As expected, a majority of patients had MDS with ring sideroblast and were categorized in the very low or low risk IPSSR. The majority of patients had available molecular data, especially for SF3B1 status, and more than 90% were mutated for SF3B1. As you can see, the majority of patients needed transfusion, and the majority were failing into the high transfusion burden category. So after Luspa failure, 93% of the patients maintained Luspatercept at full dose, and the concomitant ISA was mostly epoietin. The most frequent strategy was to initiate ISA at standard dose, then subsequently doubled after a few weeks, but some patients started directly at full dose because it was a real-life study. The median duration of treatment was 5 months, and 70% of patients received at least 16 weeks of the combination. So as you can see, we observed a transfusion independency rate of only 14% overall, and 24% in patients who were still on treatment and so evaluable at week 16. The erythroid response rate was at 20% overall and 29% at week 16. 8 patients maintained erythroid response during the follow-up from 12 to 19 months, and 3 patients relapsed under treatment after 2, 6, and 12 months. To note, 9 and 5 of the 11 responders has prior response to ISA or Luspatercept, respectively. We tried to identify, and we failed to identify a prognostic factor regarding the classical clinical or MDS feature, including the molecular landscape. And finally, the majority of patients discontinued treatment, mostly due to lack of response. We only observe 4 adverse events leading to treatment discontinuation and 1 MDS progression. So in conclusion, the addition of ISA after Luspatercept failure may restore erythroid response in a subset of patients, but we observe lower transfusion independency and erythroid response rate with this combination compared with previous series. I clearly don't have the answer why, but our patients were both refractory to Luspatercept and ISA as single agent, what is quite different than the US study. The majority of our patients were falling into the high transfusion burden category, and they were heavily pre-treated with more than 50% of them received more than 2 prior lines, including lenalidomide and ISA combination. Anyway, the safety profile was acceptable with few additional effects than with the monotherapy. But clearly, the study highlighted the need to have prospective data to maybe find who could be beneficial of this combination. So I want to thank first Maud Daveny, with whom I conducted this registry and this study, of course Pierre Fenot for this help, and all the GFM collaborators who included patients in this study. And I would to have a thought to my team in the Department of Internal Medicine in Toulouse, which is in southwest France, and which is the first city to visit in 2025 if you look at the Lonely Planet website. So we're still on May, so don't hesitate to come. Thank you.
Thank you. Thank you for the presentation. Do you have data about endogenous erythropoietin at the beginning of the treatment, and if so, does it any impact?
Do you mean the EPO level? No, because we didn't perform this test in France, so in routine practice, so we don't have. It could be interesting in a prospective study.
Regarding the EPO use, EPO alpha or darbepoietin, because darbepoietin is used in a low dose level of only 150, do you have data of response? Those patients responding, are those in the arm of EPO alpha or darbe? Do you remember?
I think I don't actually have the answer to the stratification of response regarding the type of epoietin, the EPO, yeah, but I could.
Thank you very much. Thank you. So we close this session, and thank you.